Welcome to the second annual Injury Prevention Center Research Symposium Abstract Session on Violence and ACEs. I am Dr. Sarah Stoddard. I'm an associate professor at the University of Michigan School of Nursing, and I'll moderate this session today. Thanks for joining us. We are so glad you're here. As a reminder, the session is being recorded. Only the presenters and moderator will be visible. Chat is disabled, so please use the Q&A function for all questions. If you have a question for our presenters, please ask by typing it in the Q&A feature at the bottom menu bar at any time, and please indicate who your question is for by including their name at the beginning of your question. Q&A will take place after all the abstracts have been presented, but we encourage you to send in questions throughout the session so that we can have a chance to review them. We will answer as many questions as time allows. Our presenters will have 5 minutes to present their abstract. We will share their slides while they are presenting. All abstracts can be found on the Center's Symposium webpage, and I will put that in the chat. I believe I can do that as we get started. There are 3 other abstract sessions occurring at the same time. And as much as we want you to stay in our session and listen to these great presentations, do feel free to visit other sessions. Recordings of all sessions will be released in the coming weeks. Now join me in welcoming our abstract presenters. I will introduce everyone now so that there is no interruption in the flow of the presentations. Please welcome Taylor Hutala, MPH from the University of Michigan Injury Prevention Center and Department of Emergency Medicine, Brian Carpenter from the University of Michigan Injury Prevention Center, Nishit Patel, MD, PhD from the International Injury Research Unit, Johns Hopkins Bloomberg School of Public Health in Baltimore, Maryland, Robin Feiss, PhD from the Center for Injury Research and Policy, the Abigail Wexner Research Institute at Nationwide Children's Hospital, Jasmine Morini and Michaela Murphy from the Healthy Minds Network here at the University of Michigan, and Vishka Kalra from the Department of Health Education and Health Behavior in the School of Public Health, also here at the University of Michigan. Presenters, when it's your turn to present, please turn on your audio and video and then turn them off once you are done. Okay, we'll begin sharing our presentations and get started now. Thank you.
Hello, my name is Taylor Hutala and I am a project coordinator at the University of Michigan Injury Prevention Center. Today, I will be presenting on a project in which we analyze the use of shared risk and protective factor language in some of Michigan's injury prevention legislation, and also the technical package that was created as a part of it. I'd like to first acknowledge the other authors listed here, as well as our MDHHS partners who were integral to this work. Our center partnered with MDHHS and worked on evaluating some of their core state violence and injury prevention programming, otherwise known as core SVIP, which focused on the topic areas of abusive child head trauma, teen dating violence, and child car seat restraints. After meeting with stakeholders from this group, we discovered a need to track legislation related to these topic areas, and also an interest in understanding the influence that the CDC's shared risk and protective factor work was having on state legislation. And so as a result, we decided to begin this project. The analysis team focused on legislation from the 2017-2018 and 2019-2020 legislative sessions and started by identifying pertinent legislation related to the core SVIP injury topics of teen dating violence, abusive child head trauma, and child car seat restraints. This was done by creating a list of key search terms related to each of the injury topic areas that could then be used to flag potential legislation of interest. Once we identified the legislation, our next step was to develop a process for analyzing shared risk and protective factor, or SRPF language, used in the legislation. In this case, SRPF language is used sort of as a proxy to describe whether selected search terms related to shared risk and protective factors were present in the legislation. So the shared risk and protective factors were defined for the 3 topic areas using information from the CDC and also published literature. Then search terms were developed for these SRPFs using previously defined search terms from the CDC, as well as any missing terms identified by a team of experts at our center. Anytime one of these terms popped up, our team determined whether the term was being correctly used in the bill, meaning that the flagged term was accurate. If for the protective factor, access to mental health care, for example, and the language in that bill indicated a provisioning of resources to, say, dating violence victims to seek mental health care, then yes, that would be included. But on the other hand, if the term therapist was used in reference to therapists being mandatory reporters, and it didn't exactly address access to mental health care, then this would not be included. And so after evaluating the use of shared risk and protective factor language, the team used this information to also look at some characteristics and outcomes of bills as it relates to SRPF use. And then finally, we compiled our results and a detailed overview of our methods to create a technical package for those interested in recreating this process. Here, I'll briefly go over some of our findings. So the majority of bills analyzed contained SRPF language, which you can see here on the left. 62% contained SRPF language, while 38% did not. Also interesting to note is that teen dating violence bills were significantly more likely to contain areas. We also examined the socio-ecological level at which SRPF language was used in the legislation, and we found that most of these bills operate at the level, as you can see in the middle graphic, while bills operating at the societal level were a lot less common. You'll notice here some under multiple categories are a bit larger there. And then lastly, when looking at bill passage, we observed that most bills contained SRPF language regardless of passage. A more substantial majority of bills that passed, 3/4, did contain SRPF language. However, considering the complexity of the legislative process, we weren't able to infer that SRPF language was predictive of bill passage. This is just a brief snapshot of some of our results, so I encourage you to view our technical package for additional findings. The technical package we developed includes not only our own results, but also step-by-step instructions, example search terms, and protocols for stakeholders to complete a similar analysis of their own. It includes everything they would need to do this, and it's believed to be the first of its kind. Ultimately, we hope that it'll help contribute to a better understanding of how SRPF language can impact legislation and potentially lead to more impactful legislation in the future. The package can be found on our website, which you can access via this QR code or using the link above. Thank you.
Hi, my name is Brian Carpenter, and I'm a senior undergraduate student at the University of Michigan studying philosophy, politics, and economics. Today, I'll present an overview of our work involving checkpoints and evidence-based teen driving intervention. I've been supporting this work closely with Beth Costello, who is an Injury Center staff member and coordinates this checkpoints work, as well as Jessica Roach, who is managing director of the center for much of this project. Checkpoints is part of the CDC-funded Injury Prevention Center's motor vehicle crash focus area, one of the CDC's areas of priority, and has been the subject of website redesign and dissemination work we have done over the past 2 years. Next slide, please. Checkpoints is an evidence-based intervention aimed at supporting parents and helping their teen drive more safely as they become newly independent drivers, the most dangerous time in their driving progression. It incorporates educational content on teen driving risks through videos and tabs with reading material, statistics, and recommendations. And importantly, it includes an interactive tool for customizing a parent-teen driving agreement. Checkpoints complements graduated driver licensing, in other words, GDL, encouraging parents to set stricter limits than those of GDLs when adolescents begin driving independently. This supports parents in setting teen rules, parent rules, and consequences to be reviewed at 4 future checkpoint dates, with expanded driving privileges at each point. In 2011, The intervention was first adapted into a website by a team led by the University of Michigan Transportation Research Institute. The Injury Prevention Center redesigned and relaunched the website youngdriverparenting.org in 2019, and then again this year. Through this effort, we aim to shift the intervention from more of a highly flexible resource to a more guided pathway for parents. Still underway, this redesign involves creating new instructional animated videos to update much older versions, enhancing imagery, enhancing the site's interactive tool, and making opt-in email reminders for future checkpoints. We initially launched the updated site in 2019 with limited promotion via our center's communications, such as our social media like Twitter, our newsletter, and website. We have been grateful for partners in Michigan, Tennessee, Kentucky, and Austin who have also helped disseminate our work. Next slide, please. To assess the degree that our efforts have affected Checkpoint's website usage, we looked at new users over the period of 2 years before and then 2 years after the launch. After our initial launch in 2019, through this year to date, we saw an increase in users of 880% over a similar period prior to launch, and an increase of more than 1,200% page views over that same time period. We also saw an increase of 30% in parent engagement in terms of time on the website and pages per visit. We also saw an increase of over 1,150% in the number of parent-teen driving agreements formed. We now have more than 5,300 users on the site, which represents users from nearly all US states and several countries across the globe. Next slide, please. In conclusion, Checkpoints offers a structured, predefined pathway for parents to use with their teen as they begin driving on their own. It allows for a gradual progression through riskier driving scenarios only after an agreement is met. That includes both parent and teen rules and consequences or rewards. As you can see on this screen, we have shown a part of the sample agreement with 4 columns, each representing the gradual progression to a riskier driving situation. By creating and promoting a more engaging, updated site, we have been able to increase awareness through site usage and helped reduce the rate of teen crash. Now we aim to complete our redesign and translate the site into Spanish, allowing our partners to gain traction with Hispanic populations in their areas. Thank you for your time.
Hi everyone. Today I'll be presenting our findings from Mumbai regarding one of our projects saying on helmet use behavior among motorized two-wheeler riders in Mumbai, a 5-year observational study that was carried out between 2015 and 2019. I would like to thank our collaborators from both Johns Hopkins School of Public Health and Indian Institute of Technology, Mumbai for working on this project and carrying out the initial analysis and results. So just to give you a quick background on road injuries, we all know that road traffic injuries continue to be a major developmental issue in most low-income countries. And in India alone, India actually represents 11% of the global 1.35 million deaths that are lost on the roads. While the Indian traffic scenario is quite heterogeneous from other high-income countries, and it's predominated by two-wheeler riders mostly. And Mumbai is a highly densely populated city in terms of both population and the vehicular density. So just a lot of lives can be saved by stringent enforcement and monitoring compliance with key risk factors like helmet use, speeding, seatbelt. And correct helmet use actually reduces the risk of death by almost 69% and risk of head injuries by 69% and deaths by 42%. Therefore, we present the preliminary findings of helmet use behavior among motorized two-wheeler riders in Mumbai. Can you go to the next slide? So this was a multi-round observational study that was carried out between 2015 and 2019. We had 10 randomly selected locations using a standardized protocol for all the cities, for all different cities that were in the project. Full representation of varying traffic models between different days and times of the day, as you can see in the column on the right. And the helmet was defined as a standard and a non-standard helmet. So whether it was strapped or unstrapped. We had 2 researchers per site, and data was presented using descriptive and multivariate regression analysis. So you can see the picture below, the types of helmet that we were trying to capture from the roadside observational studies. So full face, open face, whether it's a half faced or tropical, or whether it's a non-standard helmet that is not conformed to any of these 4 criteria. Next slide, please. So from the initial results we had across the 8 rounds and 5-year project, we got about 324,000 observations. And the descriptive analysis showed that at least so overall helmet use among motorcycle occupants were increased by 35% from 2015 to 2019, and 66%, to 60% in 2019, while correct helmet use actually remained low to about 35% in 2019. Helmet use among passengers, as you can see from the graphs, is almost less than 1%. And also motorcycle riders with greater than 2 occupants had a lower compliance rate of monitoring with helmet use compared to those with less than 2 occupants. So less than two occupants, they had a compliance rate of about 72% of helmet use, while greater than 2 occupants had a compliance rate of about 55%. That's the riders. While for passengers, again, the number of occupants did not matter. It was just consistently below less than 1%. Now, the adjusted odds for not wearing a helmet was significantly higher for industrial and commercial areas. Passengers who were greater than 2 riders per bike, and no visible presence of any law enforcement, that is camera or police, and weekends. Could we go to the next slide, please? So basically, this study actually highlights the low prevalence of correct helmet use among all riders and dismal use of helmet use among passengers. And it actually calls for a multi-sectorial engagement to promote correct helmet use, especially among passengers. And multi-round observation studies actually, they'll enhance a robust assessment of all different individual and environmental factors, which influence helmet use and allow for evidence-based policies, revisions, and enforcement activities for improving correct helmet use among all riders. Thank you.
Hi, I'm Robin Feiss. I'm a postdoc at the Center for Injury Research and Policy at Nationwide Children's Hospital under Dr. Ginger Yang. I just wanted to start by saying thank you to all of you for tuning in today, and I'm very excited to be here presenting our research on rural-urban differences in behavioral outcomes among adults with lifetime history of traumatic brain injury. I'd also like to thank my colleagues at NCH, Ohio State University, and Kent State University for their contributions to the project as well. So just to provide a little bit of background on our rationale for this project, research has shown that there are strong relationships between lifetime history of TBI with loss of consciousness and behavioral issues, as well as relationships between location of living and behavioral issues. But how location of living, for example, living in a rural versus an urban area, might moderate the relationship between TBI and behavioral health issues like unhealthy alcohol use or mental health problems has not been addressed. Particularly given that rural populations have decreased access to quality healthcare compared to urban populations, we wanted to investigate how rurality may moderate this relationship. Next slide, please. So for this study, we examined this using data from the 2016 through 2019 Ohio Behavioral Risk Factor Surveillance Survey. And we used multivariate logistic regressions to determine the possible impacts of TBI with loss of consciousness and location of living on binge drinking, heavy drinking, depression diagnoses, and number of poor mental health days in the past 30 days among a sample of 16,941 non-institutionalized adult Ohioans. Next slide, please. So after weighting, our sample represented was 52.1% female, 43.1% were ages 18 to 44 years old, 81.2% were white, and 77.1% were living in an urban area in Ohio. So in total, 16.9% reported having experienced a TBI with loss of consciousness during their lifetime. 16.9% reported binge drinking and 6.6% reported heavy drinking. Additionally, 20.1% reported a depression diagnosis and 33.4% reported having at least 2 poor mental health days in the past 30 days, while 14.2% reported 14 or more poor mental health days in the past 30 days. So importantly, we actually found that the interaction between TBI with loss of consciousness and location of living was not significant for any of our behavioral outcomes. So we actually did not include that in our analysis. But we did find that after adjusting for gender, age group, race and ethnicity, and lifetime history of TBI with loss of consciousness, that living in a rural area was associated with reduced risk of both binge and heavy drinking, but was not associated with mental health issues. Additionally, as expected, regardless of location of living, lifetime history of TBI was associated with increased risk of binge drinking and heavy drinking, as well as reported depression diagnoses and reporting more than 2 and more than 14 poor mental health days in the past 30 days. Next slide, please. So overall, we found that rurality did not moderate the relationship between lifetime history of TBI with loss of consciousness and any of our outcomes, but we did find that those living in rural areas had a reduced risk for unhealthy alcohol use. And we also added to the existing evidence that lifetime history of TBI with loss of consciousness is associated with unhealthy alcohol use and mental health problems. So these findings support the need for inclusion of TBI screenings as part of mental health history intake evaluations. And finally, given that those living in rural areas may have limited access to quality healthcare, including mental health care compared to those in urban areas, future research and health policies should address access to mental health services following a TBI among rural residents.
Hi, everyone. Welcome and thanks for coming. Our presentation will describe the prevalence of concussions, both diagnosed and undiagnosed, among college students and examine possible links between concussion, depression, anxiety, and suicidality using data from the 2019-2020 iteration of the Healthy Mind Study. Slide, please. So I wanted to introduce the Healthy Mind Study. It is an annual web-based study examining mental health, service utilization, and related issues among undergraduate and graduate students with the ultimate goal of informing evidence-based practice and mental health policy and programs in higher ed. Since its national launch in 2007, HMS has been fielded about 400 colleges and universities across the United States with almost half a million survey respondents.
Like Michaela said, this survey was given to students in the 2019-2020 school year. The survey is distributed through Qualtrics and usually takes about 20 to 25 minutes for students to complete. The core modules of the survey, or the modules that all schools complete, are demographics, mental health status, and mental health service utilization. So understanding sort of what that school student body looks like, what difficulties they might be endorsing, and then are they using services that are offered at their institution. And so particularly looking at the questions we had today about the relationship between diagnosed and undiagnosed concussion and mental health outcomes, we looked at group differences between race and gender, so white students and students of color, and then men and women. And then also concussion sort of outcomes related to mental health. So as folks probably know, concussion can cause a number of different changes within the brain physiologically. And one of those can also be mood. So looking at depression, anxiety, and suicidal ideation. Next slide, please. And so what we found is that in doing t-tests between group differences for race, so between white students and students of color, there were no differences in students, or no differences in the amount of diagnosed concussions that students reported, and then no differences in undiagnosed concussions. So that undiagnosed concussion, students were given a sort of description of concussion and then asked to report if they felt they had had those symptoms and were not formally diagnosed by a medical personnel. Additionally, between men and women, we don't see that men and women are reporting any differences in diagnosed or undiagnosed concussion. So there appeared to be no group differences. In transitioning to the relationship to mental health outcomes, looking at depression, there appeared to be no differences or no relationship between diagnosed concussion and depression nor undiagnosed concussion and depression. This also extended to both anxiety and suicidal ideation. So there didn't appear to be any significant relationship between a concussion and endorsing any of these mental health outcomes. Next slide, please. And so what does this mean? One, it suggests that concussion is consistent between genders and races, at least within this specific sample. And also that displays no relationship between concussion and negative mental health outcomes, again, in this sample. So one thing to note is that the Healthy Mind study does have a fee associated with it. So it may be that the institutions that could afford to participate in this survey also had resources available for their students to better protect against mental health outcomes, as well as facilitating reporting amongst their students. So moving forward, a few questions of do traditional health disparities extend to concussion injury? And then what policies might be shaping what we're seeing? So do schools have concussion policies that are in place that are facilitating students getting the care that they need? And then what additional populations might be differentially impacted, such as athletes or students who are also veterans? So that's all. Thank you.
Good afternoon, everyone. My name is Lashaka Kajra, and I'm a second-year graduate student in the School of Public Health. I'm here to briefly present a paper I worked with my supervisor, Dr. Sarah Stoddard, over this year. To introduce this topic, I would like to begin with introducing who peer recovery coaches are. So peer recovery coaches, or PRCs, are certified professionals with lived experiences of substance use and recovery, and who facilitate linking people with problematic substance use to care. So they provide mentorship and support for individuals engaged in substance use treatment services. And given the similarities in personal history and demographic factors, they may be particularly well suited to overcome stigma and to improve retention of individuals from low resource communities in care. The COVID-19 pandemic has challenged the ability of PRCs to offer direct one-to-one support and interaction with clients, specifically among low-income individuals who may have limited access to resources, including technology, to engage in remote care. So the purpose of the study was to understand the impact the COVID-19 pandemic had on PRCs, as well as their clients in the low-resource community, and to identify barriers and facilitators to supporting individuals' recovery and delivering PRC services during the pandemic. Next slide, please. For the purpose of confidentiality, all identifying characteristics such as occupation, city, ethnic background, etc., have been changed. This study recruited PRCs who worked in agencies serving individuals from low-resource communities engaged in substance use treatment via purposive sampling and snowball approaches for semi-structured interviews. And a total of N is equal to 6 PRC participants were recruited for this study. Using a qualitative research framework, thematic analysis approach was used to identify and analyze the data obtained from the semi-structured interviews. Next slide. So we obtained 4 main themes with 8 sub-themes that were identified, and the 4 main themes were impact of the pandemic on the PRCs, impact of the pandemic on the clients, the barriers to supporting services, and the facilitators to supporting services. So looking at the impact of the pandemic on PRCs, on one side, participants reported that the pandemic affected their recovery, with one participant actually saying that it had affected them emotionally, spiritually, and mentally. On the other side, participants also reported that due to their lived experiences, they had unique resilience to face the challenges of the pandemic. Looking at the impact of the pandemic on the clients, the participants reported that the pandemic had negatively impacted their clients in terms of increasing social isolation because of lack of face-to-face connections. They feared that the clients also might relapse because the hardships for clients increased during the pandemic, and many of them were struggling to pay bills and get basic amenities such as food and clothing met. As far as barriers and facilitators go, while virtual modality has reported benefits of increased access and comfort of receiving services, PRCs also reported that it led to difficulties in establishing a working rapport with clients. And due to disengagement from the side of their clients, they also faced issues of non-compliance from some of their clients. Next slide, please. To conclude, the pandemic affected the physical and mental well-being as well as recovery trajectories of both PRCs and their clients, with PRCs experiencing increased higher levels of stress and uncertainty. So moving forward, the implications would be the need for more support and supervision for PRCs, as well as the need to promote resilience, the need for technological resources and access to remote peer delivery of services for engaging low-income individuals in substance use treatment. Thank you for your time.
Great, thank you everyone for your presentations. We do have time for questions. As a reminder, anyone in the audience can post a question to the Q&A box or your panel at the bottom of your menu or the bottom of the screen. And then the presenters can also turn your cameras back on so we can see everyone. I'm not seeing any questions from the audience yet. We'll give people a couple minutes, and I have a few questions that I can ask, but does anyone on the panel have questions for any of the other presenters first? We can also think about that if anyone else would like to ask questions. I will ask a question then. So I'll maybe kind of go through the order that we started. So Taylor. So thinking about kind of the analysis you did and maybe future iterations of it, what do you think can be done to gain better insight into how the SRPF language can impact legislation?
That's a good question. I think there's a few things that could be done. Expanding the number of injury topics would be a good one. I know we only focused on 3 for our project. So kind of expanding the topic areas to further analyze the use of SRPF language across a broader range of injury prevention topics. I think also finding a way to analyze SRPF approaches in legislation, in addition to just the SRPF language like we did. And then I think another thing that my team talked about was potentially looking at how often this language is being used as opposed to just whether or not it's present, and kind of seeing how that affects the legislative outcomes.
For anyone who maybe didn't hear, that maybe joined us a little bit late, can you remind us what SRPF is?
Yeah, so it stands for Shared Risk and Protective Factors.
Perfect, great, thank you. Okay, Brian, can you talk a little bit about how checkpoints is different from information that parents might normally, kind of get about their teen driving and taking part in a driver's education course?
Yeah, definitely. I think normally in a driver's ed course, parents sort of learn the requirements of their state's rules for driver's education, such as like the hours that they can practice with a parent, when they can be on the road, number and type of passengers allowed in the vehicle in the early stages of licensing, and also sort of the types of risks that drivers face when they're first driving. But through checkpoints, it provides a more thorough process for parents to remain involved after their teen is licensed, with more of a structured process through risk exposure. The parent-teen agreement suggests the exact criteria for gradual exposure to greater risks at 4 different checkpoints, and it calls for parents and teens to agree to the rules for each stage, even including parent rules such relating to distraction. So I think sort of that gradual progression and the continuation of driver's education after their child has their license is kind of the big difference there between the 2.
Great, thank you. Okay. And again, if anyone has a question, they can enter it in the Q&A. I'll just remind everybody. Nishit, yeah. How did the researchers ensure the roadside data quality control in your study?
So we made sure that all the roadside data collectors were trained before each round began. So first we had an initial training period, and then we had a practice session where we got the data, we analyzed it, and we checked whether the researchers are ready to go on the road or not. So once they started going on to the observational areas, so after every round, the data that came in was actually cleaned, analyzed, and made sure that it was fixed before we go into the next round. And every site had 2 researchers. So both the data from both researchers was compared, the type of the data that they were entering and all. It was all the paper-based data. So we made sure that they follow the protocols that have been outlined in our protocol manual. Yeah.
Great, thank you. Robin, kind of going through the list. Anyone have I'm still watching the question and answer. So, but Robin, can you talk a little bit about kind of what prompted you to kind of look at the research question that you shared today in the study that you shared today? Oh, there you are. Yeah.
Yeah. Sorry, I got kicked out of the Zoom.
So did you hear the question?
Yeah. Yeah.
Okay,
yeah. So I wouldn't say there's kind of like a specific project or manuscript or anything, but for me, I've always just been interested in how physical activity and injury can impact mental health, and particularly in populations like rural populations that might not have easy access to quality healthcare services. So when I started at NCH, my PA, Dr. Ginger Yang, connected me with Dr. John Corrigan at OSU, who's just done an incredible amount of great work in the area of TBI and behavioral health issues. So it just seemed kind of like a perfect fit for both of our interests. And it was also something that we found just really hadn't been explored before. So it was just kind of just a really good fit for both of us, and it turned into a really interesting project.
great, thank you. So either, Jasmine or Michaela, so the study that and the data that you shared, there are multiple institutions participated. Kind of how do you think the data kind of looks maybe different across different institutional demographics?
Yeah, I think that majority of our sample right now are PWIs or predominantly white institutions. And so I think that can affect how the data looks. There's currently a grant being developed to start conducting the survey at minority serving institutions. So I think that might shift how the data looks, as well as I think Robin sort of spoke to, as well as more rural schools that have folks from more rural populations might also change how some of that data looks as well.
Okay, then Vishka, so you talked about PRCs, and I know this work because this is some of my work. So can you share with everyone kind of what we found around thinking about some of the strategies that the PRCs reported using to cope with stress in our interviews?
Okay, so we found a couple of strategies that PRCs used, and one of them said that it was difficult for them to stay motivated, but what actually motivated them to cope with the stress and to get through the pandemic was reconnecting with loved ones. So that was one of the strategies that was used. Another strategy that was used was physical exercise. So one of them reported that doing physical exercise, whether within the house or just around the house, was something that helped them cope. And yet there was another participant who said that what helped them cope was the fact that they were able to continue their care from an in-person modality to an online modality. and they could like go meet their support group online, and that's what like helped them cope with the stress.
Anyone in the group have questions on the panel that they want to ask each other? Otherwise, I'll keep asking a few more, but I'd love if anyone else has questions. And if our attendees have questions at all, they're welcome to put it in the Q&A, and I'm watching that. Okay, well, let's see. Brian, how has the Injury Prevention Center worked with partners to promote kind of the checkpoint site and its use?
Yeah, so as I mentioned during my presentation, the center's worked with partners in Michigan, Kentucky, Tennessee, and Texas who have supported the program and assisted in dissemination. All those partners also have been providing design feedback and advice along the way. And then some of those partners have helped us disseminate to drivers education associations, helping us reach an additional 1,500 instructors. And others have helped us with ideas on moving the website design into like a more of a guided pathway.
So Taylor, have you considered looking at bills by type of impact? For example, bills that focus on prevention versus bills that focus on treatment?
Yeah, that's actually something that we looked at. We looked at 4 different categories: prevention, social impact, post-care, and treatment. And we found that a majority of the bills identified focused on prevention, and very few bills focused on treatment. The same was true for the bills that contained the shared risk and protective factor language. Unfortunately, I didn't have enough time to cover it in my presentation, but it's something you can read more about in the technical package.
Great. Nashit, so I saw, you showed the different helmets in your presentation. Were researchers able to differentiate between the different types of helmets and the different straps in your study?
It was actually a challenge to differentiate between different types of helmet because of the moving traffic itself. And one of our strict criteria was that the observers are supposed to be standing at near an intersection or where there's a traffic signal. So naturally, when all the traffic comes, it either slows down or it comes to a stop. So that way we could capture most of the helmets. And I think looking at the straps was a bit difficult with the full-faced helmets. Although they could, when the traffic had stopped, they could still see the straps. But I think compared to the other like cap helmets and all, it was a bit difficult to see the straps for the full-faced helmets.
Hey, Robin, do you have any thoughts on why living in rural areas may influence drinking behaviors but not mental health issues?
Yeah, so this is really interesting, right? Because we a lot of times see that drinking behaviors and mental health issues kind of coincide with each other and go together. Here, I think it could be a couple different things. One possibility is that mental health diagnoses and just general issues in this population might be a bit underreported, especially with lack of access to mental health care services to get that diagnosis, or even just the stigma surrounding mental health issues in rural populations and communities. On the other hand, there's aspects of rural communities that might contribute to better mental health. Such a lot of times we see that they report greater feelings of connectedness and community support among rural communities and populations. So we may actually, that might be one of the reasons why they're not seeing those mental health issues there. So my best guess after all that is that it's likely kind of a combination of these, as well as influences from other cultural, social, and economic factors that can contribute to that.
Great. Well, I'll just ask a follow-up. So what do you have thoughts for kind of next steps related to your work and your findings?
Yeah, so I think as far as the next steps for research, I think there's kind of two different interesting directions to take this. The first is looking at possible influences of different characteristics and natures of TBIs. For example, looking at like the number of TBIs that a person has experienced, the severity of the injury, and another more recent one that people are looking at a lot is the age at which a person had their first TBI, as we're seeing that TBIs that occurred in childhood might have a greater impact on some of these types of things due to the developmental impact that might have. And then also one of the things we could look at as well is the recency of their most recent TBI. Is that something that's collected as well with the BRFIS? So we can look at all of those on the long-term behavioral outcomes. And I think the second area, which I kind of alluded to in my talk a little bit, is looking more into healthcare access and utilization following a TBI among rural populations. And then lastly, just kind of as far as to how the findings can be used, one of the practical implications that I think is kind of an easy next step is asking about TBI history in mental health intake evaluations, given that we're seeing pretty consistent and strongly established connections between TBI and mental health.
So Brian, I have a question for you from the audience. So this person who is asking the question is kind of wondering about the starting age for driver's education and is commenting that as an emergency medical service provider and critical care nurse and now an injury prevention educator, that there's a lack of cognitive function of the current age. Despite driver's education, the majority of crashes are from the younger population. So I'm wondering if you have any thoughts about that.
Yeah, definitely. I think part of the problem there is that with driver's education, it kind of stops once the kid gets their license. And sort of as he mentioned, they are only 16 years old. They need to continue learning and they only have 30 or so hours of experience driving, and most of that is with either a driver's education instructor and or their parent, but now they've transitioned into driving on their own, so that education needs to continue. And sort of teens also have a tendency to sort of stare out the window and not really stay as engaged and maybe not have as high of attention span as them, and they definitely have a high distraction rate compared to older populations. And I think that's why checkpoints is really important, in that it sets these very stern restrictions on not only distractions such as passengers, but also phone usage and that kind of thing. And I think one thing that's useful there is that it also will set restrictions on parents' phone usage when they're driving, because one thing a lot of studies have shown is that parents who drive riskier are more likely to have a teen that drives riskier and also less distracted. So I think the big thing for sort of even with driver's education is continuing that education, given that they are young and their cognitive function maybe isn't as high as some of the older drivers on the road.
Nasheed, actually, I'm going to go back to you, and it's what has kind of come out of some of your study, or maybe some kind of outcomes either around, have there been any changes in laws or enforcement, and do you have thoughts around next steps as well, kind of in that area of work?
So regarding the enforcement, so we have two kind of enforcement. So once there was a local enforcement that was passed in 2016 that mandated all local local two-wheeler dealerships to provide 2 helmets to all motorcycle buyers. So that was trying to offset the cost of helmet onto the buyer himself. So because one of the reasons of not wearing helmet is the cost. Having a standard helmet versus a non-standard helmet. So a standard helmet is a bit expensive. So that was one of the laws that was passed in 2016. And recently in 2019, they also passed the amended Motor Vehicle Act of 2019, where they increased the fines of for not wearing a helmet by almost 10 to 20 times. So initially, if it was 1,000 rupees, now it's almost 10,000 rupees, which is a huge rise in the fines for not complying with the helmets. So in terms of compliance monitoring, we're actually going to the next phase of our monitoring post the MVA 2019 amendments. So at this point, we're now trying to assess the compliance after the laws have been passed. So what has changed? Is there any change on the compliance or not? So again, we will be going through the same. So right now it's supposed to be from 2000. It was supposed to be from 2020 to 2025, but due to COVID, we had to extend 1 more year. So now it's 2021 to 2025. So we will have that iterative rounds again for helmets observation, not only helmets, but also seat belts and drunk driving and speeding as well. Yeah.
Wow, great, thank you. Okay, let's see. Taylor, have you thought of ways to leverage your findings and collaborate with policymakers regarding the impact of the shared risk and protective factors language on legislation?
Yeah, this is definitely something we've thought about. We've considered connecting with our government affairs team at the university to see how they can sort of show us how to do that in a productive way. But since it is our first iteration of this project, we also hope to continue this type of work in the future to gain some more insight into how shared risk and protective factors influence legislation. But eventually we hope that this work can lead to that type of collaboration and hopefully more impactful legislation in the long run.
Great. Let's see. Well, Brian, I'll go back to you. And I don't remember now how much you talked about any evaluation data in your presentation, but what do you guys have now as far as what the evaluation data shows on whether checkpoints works as far as reducing teen crashes?
Yeah, so one of the most prominent evaluations of checkpoints effectiveness included the University of Michigan Transportation Research Institute, the original developers of the website, and also an intervention developer in Dr. Simons Morton. In a paper, the effectiveness of a brief parent-directed teen driver safety intervention delivered by driver education instructors, the researchers found that checkpoints conducted by driver education instructors resulted in more use of parent-teen driving agreements, greater restrictions on high-risk driving, and it also resulted in less high-risk driving. The teens who participated in the intervention were more likely to report that they had used a parent-teen driver agreement and also had restrictions in terms of teen passengers in the cars and also driving on weekend nights, high-speed roads, and bad weather in their first 6 months of licensure. The teens also reported less high-risk driving. In several previous studies, the Checkpoints program was shown to help parents adopt an agreement and set and monitor limits on teens' early driving, reducing high-risk driving by teens.
Okay. Yay, we have another question from the audience, which is wonderful. And this one is for Robin. Do you feel that giving TBI history, so traumatic brain injury history, is acknowledged now more because of the recognition of TBI in the media versus being stigmatized 20 years ago?
As far as just be like self-reporting TBI, I think definitely people are more aware of what TBI is and maybe have kind of thought back on it and realized that they did have one and maybe didn't know at the time or something like that. But yeah, I think we've also seen that especially among youth. And we've seen kind of that increase in reporting among youth, not that it's where it needs to be quite yet, but I think we've definitely seen just that increase in awareness and acknowledgement of TBI, particularly in the last couple of years. Yeah.
So maybe one for Jasmine or Michaela. So what other mental health outcomes do you think may be related to concussions?
Yeah, that's a great question. So there have been several negative mental health outcomes that have been related to concussions and TBIs, one of which being depression, anxiety. It can been known to worsen pre-existing mental health conditions. And there are also links to Alzheimer's in older adults. So I think the real key to negative mental health outcomes as they relate to concussions is time. The Healthy Mind study runs in college and in high schoolers. And I think one of the main reasons we didn't find a lot of correlation is that a lot of these negative mental health outcomes take some time to kind of show themselves. And I think that's kind of one of the tricky parts about studying concussions is really when to intervene and when to find out before those negative mental health outcomes become unbearable, but after they've presented themselves in some way.
So I don't know if, you're probably sharing questions, but how do you think advancements in technology might impact the results in the future of your studies?
I think that there was a presentation earlier about the use of sensors in detecting concussion, and I think that would be really change the game in terms of monitoring concussion as well as its outcomes, in that you're not relying on, in that case, athletes to report concussion, but instead there's already sort of something that warrants intervention. So I think something like that, in which it sort of decreases the burden on the student or on the athlete to seek out services, and instead it can be brought to them.
I actually have a question for Nishat. So when you're talking about compliance, are you also like giving incentives to people to comply with, the rules? Because you talk about penalizing, but are there also incentives involved?
Sorry, is that question directed to me?
Yes.
Oh, so as far as our work is concerned, we're just doing monitoring and evaluation. There is no incentive as such not to. The only incentive is that you will get your helmets free of charge. But so it's a whole consortium of work. So we do monitoring and compliance. We have other partners who do a lot of mass media campaigns, a lot of creating awareness, school modules. And there are other partners who work on critically like road engineering and all. So it's actually a consortium of partners work that we're trying to improve the compliance of all the risk factors. Not only just the risk factors, but also improve other components of road safety.
Okay.
But as such, we don't have an incentive just to the rider himself or herself to wearing a helmet.
Right.
Yeah.
Thank you.
Would you have any ideas for incentives though?
No, I was just thinking, given like the Indian climate and how difficult it is to I am from India, so just how difficult it is to get people to, follow something or do something is difficult. So even like with the penalization, I just wonder how much, I'd be interested to know how much was like the compliance of the project, the helmet use. So we're just wondering.
Well, preliminary data does show that compliance has increased, but like it may not increase for a long term. For a long-term sustained change, we need a behavioral change, which we know that takes time for the whole system to change. So it's a start, and we hope that in the next few years, like people will start complying with all the risk factors, not just the helmets themselves, but other risk factors with their vehicle standards, insurance, and all. Yeah.
I was also wondering whether you have like any, I mean, I hear you when you say that you're doing evaluation more on the evaluation side, but do you have, I see this study was focused in Maharashtra, Mumbai. So do you also have like education programs? Are you giving them education programs, telling them about like the risks of motor vehicle injuries and in their regional language to sort of amplify the message across? Is that also part of your project?
Yes, so there are a lot of mass media messages and journalism campaigns and all going on. So that work has been carried out by other partners, like for example, Vital Strategies. Then we have NATCO GDCI, and we also have World Bank as a partner. So every partner has their own set of objectives to carry out within these 5 years. So yes, mass media and creating awareness is one of the components of the intervention.
Okay, so a suggestion for maybe, and people could just jump in as well. Thinking about incentives, and does anyone want to talk about kind of incentives around either, for example, like with checkpoints, to getting parents to agree, in their teens to agree to kind of participate in programs, or to have, maybe schools participate in, engaging kids and families in programs, or, incentives for any of the projects that you're working on, or how do you engage people to participate in, in some ways for some of it's in prevention activities.
I think one of the intervention or one of the incentives that we can talk about is probably thinking about, like cheaper, if you complete a module or something, you get a cheaper insurance rate for your vehicle or something. So like complying with, let's say, for example, if you comply with helmets and all, then you get a cheaper insurance rate for your motor vehicle or your motorcycle rather. So road safety related kind of compliance, or I mean, road safety related interventions, incentives. Yeah.
Yeah, I guess I can also hop in here and answer that. I think one of the big incentives of checkpoints is that it opens up pathways of communication between parents and adults. Also, teens in Kentucky, in Tennessee, that parents are in, they also get parking passes, which I think is pretty useful for them as well to incentivize them. So I think both that monetary incentive, but also sort of that relationship incentive between parents and their teens, both help engage checkpoints.
I have a cat who's now talking, so hopefully you won't hear him. Anyone have other questions? Is there, well, we might be getting one from the audience. I can be hopeful. Let's see. Rishika, why don't maybe you can share just a little bit of more, what suggestions did our participants offer to help support their clients in our interviews? Can you? Yeah.
So basically, whatever suggestions are, they come from their lived experiences, and considering they're limited in terms of providing support. The suggestions that they offered to their clients was to be flexible, to be open-minded, to be willing to change. And it was also in terms of like not looking at events overall, but to take one day at a time and move forward. So these two were the themes that were found across, and most participants agreed to this. So.
Great. Well, maybe we don't have a question. Any of the panelists have questions for each other we haven't talked about? Anyone else we talked to a couple people kind of about their thoughts for next steps. Does anyone else have kind of related to their studies thoughts for either next steps or how it could be applied maybe to practice or policy? Just throw it out there for anyone.
I touched on this briefly earlier, but as far as next steps for this shared risk and protective factor analysis, I think one of the big things is kind of waiting for more legislation to come out so that we have like a larger sample to look at. I know with our project, we had like a limited sample. So it'd be nice to kind of continue this work and keep looking at the new legislation as it comes in. Also, I think expanding the injury topics that we look at, because again, I only looked at 3 injury topics, but there's a lot more types of injury prevention legislation out there that I think would be neat to look at.
I think in the realm of concussion, it's important to look at league policies. A few years ago, for example, in the NHL, Gary Bettman basically denied that CBT and TBIs are important, that concussions happen in hockey, which we know universally to be not true. And I think that high school and colleges model their concussion policies from professional sports. And so I think placing a renewed emphasis in injury prevention research on athlete-specific concussions and really pushing those major leagues to implement concussion protocols that are consistent and well publicized would go a long way to improving the amount of reported and diagnosed concussions and ultimately increase treatment.
So I have a question for Brian. So do you think partnering with driving schools, since only students attend classes, yet parents need to be active in the GDL attended hours of driving? Kind of some parents have no idea of the state driving rules. So I guess kind of can you talk about your thoughts about partnering that way to maybe include parents, I think is.
Yeah, definitely. And I think through some of our partners, we have disseminated that information to driving schools. And I think one of the things that makes checkpoints really useful is that both the parent and teen are working on it together. And even if the parents aren't completely aware of what the rules are within their states and maybe don't have a good bearing of what they should be putting in their agreement, one thing that Checkpoints offers is a sample agreement that kind of gives parents a baseline of like, hey, these are what the standard rules look like, and we may tweak them a little bit based off what works for our family. So I think, yeah, we have partnered through our partners, given that information to some drivers' schools, and I think that is definitely something that's useful in relaying more information through parents, because a lot of, not only are teens learning how to drive, but sometimes parents are learning how to teach their kid to drive as well.
Well, does anyone have any other questions? Kind of gone through mine, and I don't know that we can kind of maybe wrap up if there aren't any other questions. Oh, no, Burton. Okay, then if anyone has another question, put it in the answer or the Q&A. Otherwise, I'll kind of do our wrap up here, and that'll give people just a couple more minutes in case they had they were being shy about a question. So first, thank you so much for joining us today at the symposium. Hopefully you were able to attend the whole afternoon, but especially joining us for our session this afternoon. I want to thank all our presenters and to our staff, Beth Costello and Taylor Hulata. I can't do it. Sorry, Taylor, for making sure today's session went smoothly. You will be receiving an evaluation survey within the next few days. We encourage you to fill it out as it helps us continue to grow and improve our event for the future kind of upcoming events. Please also fill out the evaluation survey to request continuing education credits if you are interested. Additional information can be found on the Injury Prevention Center Symposium webpage. If you are not already a member of the Injury Prevention Center, please go to our website at injurycenter.umich.edu to become one and to get access to our monthly newsletter with publications, updates, and events. And it's really not too hard to apply to be a member, so we'd love to have you. Please also check out our website for more information and opportunities that might be of interest to you or your colleagues, such as our summer internship program or our massive online open online courses. As a reminder, all sessions today were recorded and will be available on our website in the coming weeks. I will check the questions again, and I still don't see any. So I will say thank you again for your attendance, and thank you to all our presenters for their important work in injury prevention. And I hope you have a wonderful rest of the day. Thank you.